o'clock on the dot. That's not bad. Good afternoon. I'm used to doing this in the evening. Good afternoon, everyone. My name is Cleve Corner. I'm the manager of author and speaker engagement here at the Pratt Library. I'm so happy that so many of you could come out on a gorgeous day and spend time in this building with us. Before we start, just a little housekeeping. Dr. Patel and Dr. Makary will be in conversation for about 35 minutes, and then we'll have about 25 minutes for your questions. There's a microphone here, and there's a microphone over there. We ask that you bring your questions to these microphones. Not only is the program happening live in this room, but it's also being broadcast on our Facebook and YouTube pages, so the folks back home can hear the question. It also allows me to tell you that if you can't ever make a Pratt program, 90% of our programs are live streamed and archived on our website, so just a heads up on that. The most important thing for the day, although we're in an institution that is free and allows you to borrow books, we would love for you to purchase your book today. Dr. Makary's book is for sale by our on-site bookselling partner, Snug Books, based in Laurelville and Hamilton. Please purchase a book, and Dr. Makary would be happy to sign it for you afterwards. After the program, I'll escort Dr. Makary over to that table right there. I'll ask you all to hug this back wall, and we'll have him sign your book, and you can chat for a little bit longer. This afternoon, I'm happy to welcome Dr. Marty Makary to the Pratt Library to discuss his new book, Blind Spots. In it, he explores the latest research on critical topics, ranging from the microbiome to childbirth, to nutrition and longevity and more, revealing the biggest blind spots in modern medicine and tackling the most urgent yet unsung issues in our $4.5 trillion healthcare ecosystem. The path to medical mishaps can be absurd, entertaining, and jaw-dropping, but the truth is essential to our health. This afternoon, Dr. Makary will be joined in conversation by Dr. Kavita Patel. Marty Makary is a Johns Hopkins professor and member of the National Academy of Medicine. He is the author of 2 New York Times-bestselling books, Unaccountable and The Price We Pay, winner of the 2020 Business Book of the Year Award. Dr. Makary has written for the Wall Street Journal, the Washington Post, and the New York Times, and he has published more than 250 scientific research articles. He served in leadership at the World Health Organization and has been a visiting professor at 25 medical schools. Kavita Patel is a physician based in Washington, D.C., who advises healthcare companies as a venture partner at New Enterprise Associates. With extensive experience in public policy, Dr. Patel previously served as Director of Policy for the White House under President Obama and as Deputy Staff Director to the late Senator Edward Kennedy. During her tenure in these roles, she played a pivotal role in pandemic preparedness, say that 3 times, and healthcare reform efforts. Dr. Patel's research on healthcare quality and community-based interventions for mental health has received national recognition and has authored numerous papers on book chapters on healthcare reform and health policy. She is also an NBC, CNBC contributor. Most recently, she was appointed as professor of medicine at the Stanford University School of Medicine. It's my great pleasure to welcome Dr. Marty Makary and Dr. Kavita Patel to the Pratt Library.
month later, it comes out in publication. But by that time, the media ran with the headlines, and we as physicians see the brands of NIH, Harvard, Stanford, all these institutions, JAMA, it's published in JAMA, and we see the headline, we kind of get our information from it, and so that became the dogma, that hormone therapy causes breast cancer. It turns out some doctors noticed when the paper came out, there was no statistically significant difference in the rate of breast cancer in the placebo versus the HRT group. But they were crushed. The dogma was too loud,
Right.
the momentum was too strong.
Right.
You experienced it sounded like, with this
Yeah,
email, you know,
definitely.
find your patients and tell them to flush their pills down the toilet. This thing can cause cancer. Unbelievable. I found, and by the way, I don't know, there's many physicians here, you might have a better eye on this, but from my discussions with primary care doctors that I trust, they say that about 70 to 80% of doctors still believe this dogma.
Yeah, that's true.
And so 50 million women in the last 22 years have been denied the incredible benefits of hormone replacement therapy because of this dogma. And just to give you a little snapshot of those benefits, women live 3.5 years longer. The estrogen oxidizes and increases nitric oxide, which keeps the blood vessel wall healthy and soft and dilated. It also does something to the neurons. So there's less cognitive decline, 50 to 60% less cognitive decline in women who take hormone therapy, 35% lower risk of Alzheimer's, a 50% reduction in heart attacks when you start it within 10 years of the onset of menopause. And if a woman falls or is in an accident, they're far less likely to need an operation for a bone fracture. Their bones are stronger and healthier. The benefits are overwhelming, and those are the long-term benefits. That's not even talking about the alleviation of the menopausal symptoms, the hot flashes, night sweats, mood swings, weight gain, all those. There's 50 plus symptoms of menopause. But we were never taught about menopause in medical school because of the dogma that there's nothing you can do for it. The only thing out there, estrogen, which alleviates the symptoms, causes breast cancer, so we don't even need to teach it. So tragically today, a woman today in America is more likely to be prescribed an antidepressant for menopause than they are estrogen. And I found this doctor in retirement. I don't think he realized who I was or what I was doing, but I said, I'm writing a piece about hormone replacement therapy. Can I interview you on the record, recorded? And he said yes. And I said, how can you say this causes breast cancer when there is no statistically significant difference? And he started talking over me, kind of switched the subject to other articles, and I kept coming back to his own study, his own data, the one that he held up and said, this is why it causes breast cancer in 2002. The one that every doctor who believes it causes breast cancer will cite when you ask him, why does it cause breast cancer? And then he started talking sort of high-level statistics. I think maybe trying to talk over my head, but he picked the wrong dude to talk over.
He clearly
this.
didn't do his research before you showed up at his door. Yes.
So we wrestle on the statistics, and then he acknowledges at the end of this sort of contentious, long discussion that, yes, hormone therapy does not increase the risk of breast cancer mortality and has never been found to increase the risk of breast cancer. Amazing. My mom is one of the women who did not get it because the dogma came out when she went through menopause.
Yeah.
She broke her hand recently, minimally displaced. I'm sure it would not have broken.
Right.
She wouldn't have needed surgery.
Same here. Yeah, it's true.
So.
We think of, and to your point about it still permeating, it's not just kind of how doctors practice. We usually we put this into insurance benefit design. I mean, I remember there were many times like when you would prescribe it, even in kind of rare cases, even in times for patients, for example, that had gone through premature menopause due to kind of, removing their ovaries, et cetera. There would be like this alert that you would get, from the insurance company, like, did you really mean to prescribe this? So it's not just that it goes through doctor behavior, it becomes part of the infrastructure, which you've written about in your other books, which I recommend, but it just creates a life of its own. And speak more about how this goes far beyond just how doctors think. And then we've alluded to, like, it's hard to be a doctor. We're not trying to say that this is, and I think you do say this in the book several times, that doctors aren't bad people.
No. Good.
But the culture of medicine, in some ways, it hasn't changed that much from the house of God. And ironic, we're here with Hopkins, like in our backyard, University of Maryland. Some of this is from these institutions that are around us, but they're not bad people. But the system is set up in such a way that, to get back to my original comment about you, that you don't necessarily think about that patient that's in front of you. There's so much that kind of bakes into how you do your differential diagnosis or how doctors think.
Well, we need civil discourse in medicine. We need civil discourse in society. We have to have freedom of speech to speak your ideas, especially among experts talking about scientific topics. The people who challenged the dogma that HRT causes breast cancer, they were crushed. And I interviewed a couple of them in the book, including one of the co-principal investigators of that giant study that was published, which, by the way, happened to be the largest study in the history of medicine, $1 billion taxpayer dollars to do that clinical trial. And he said, whoa, wait a minute. They were gathered in Chicago at the Sofitel just before the press conference announcement about the study. They thought they were meeting for their regular study meeting. They had no idea what these results were. And he got up there, or the statistician got up there and said, well, you can throw out the agenda. There's been a discovery, a change. We found out it causes breast cancer. And so we went ahead and took the liberty of writing the article. It's already been accepted. Your names are all co-authors. And we're going to have a press conference next week and tell the world. And a bunch of them start flipping through this paper they just got handed, and they're looking at the numbers, and they're like, oh my God, you can't put this out there. And they get into a shouting match. And one of them says, if you create fear with something as sensitive as breast cancer, you will never be able to put that genie back in the bottle. And they fought this, and they were manipulated. I tell the whole backstory so people can know the truth on this. And the main guy, they tried to crush his career. They fired him from the NIH, took away his funding.
They did kind of crush his career to some degree.
Yeah, they kneecapped him for
Right,
sure. Yeah.
they did. And it's not easy. We've seen a lot of that. We're not going to spend a lot of time talking about COVID, but that's certainly been the case in COVID as well. And in terms of civil discourse, you and I have disagreed about aspects of COVID, and that's okay. It's not one person is right and all others are wrong, just like one very esteemed scientist is not always right and everyone else is wrong. Let's shift.
And just real quick, that's what I love about Kavita. That's what I love about you. I think more than anyone of all the thought leaders in healthcare, you were sort of known for your civil discourse and for your great listening skills.
My political background.
And look, she's got political credentials. I mean, she worked on healthcare in the Obama White House.
Back when we worked on bipartisan deals. But it's true. I've seen enough medicine to know, and you did write this in the book too, the best thing we can say is, I don't know. Yeah. And I felt like that struck a chord with me. Any of you in any profession, I always tell I don't have as many new patients as I used to when I had like a fuller panel, but I always tell them, I'm just going to be brutally honest when I don't know something. And Marty embodied that when he wrote kind of, I don't know. It sometimes feels like it's hard. There's pressure on us in medicine to know everything.
Right.
And the fact is any of you who have had a primary care doctor, if you get 15 minutes, that's a blessing, but most of us try to get like 7 to 10 minutes on average, and they're looking at a screen and nobody's really looking at you and kind of thinking about who you are. So part of this book, maybe we can talk about the topics. You have a number of topics. I just want to tee some of them up so people kind of understand. You cover everything from like antibiotics to childbirth, C-sections, cancer rates, so many pandemics. You talk about these like notions and these blind spots. Something that you do touch on, but we don't spend enough time on, is just chronic disease in general. It's part of this theme here. But talk to us a little bit about blind spots that, around chronic diseases, why we're not talking about them as much as I think we should, and where you see that fitting into the narrative of blind spots.
Well, on the acute care side, surgical care technique, identifying gene types and matching treatments, we do very well. We're amazing. On the topic of health, our healthcare system has a 50-year failure track record. chronic diseases now burden every aspect of American society. 93% of adults do not have ideal metabolic health. 2/3 are obese or overweight or have diabetes or pre-diabetes. Half of our nation's children are obese or overweight with fatty displacement of the liver. Autism goes up by 14% every year for the last 23 years. Who's asking why? We're seeing fertility rates go down. Autoimmune diseases have gone up to the point where 1 in every 5 women will have an autoimmune disease in adulthood. We're going backwards, people. We are not making progress. We've ignored the root causes of these chronic conditions. Basic principles around the food supply, insulin resistance, general body inflammation. We've poisoned our food supply, engineered highly addictive food ingredients. We have made our nation's children sick. We've coated our food supply with pesticides, and then we medicate them. We've got 20% of our nation's children on medications now. 40% will have a mental health diagnosis. We've got to stop and ask, what are we doing? There's all sorts of enthusiasm now about the GLP-1 drugs. There's, you're hearing the politicians, no offense, but the politicians are talking about the Medicare's ability to negotiate drug prices.
Drug pricing, yes.
Great, that's great. Okay, good. You had a win, that's great. So, but it was kind of a bipartisan thing. I think both parties won. But that's a $6 billion savings in an expanding $287 excess billion cost healthcare system as a part of a $4.7 trillion healthcare system that is expanding at a rate of 8% a year in the commercial market and 4% a year in the government market. So you save $6 billion in a $4.7 trillion expanding healthcare system.
And didn't really fundamentally change the system
It's
of
not,
care
yeah,
at all. Like,
exactly.
And just doing a discount off a list price.
That's right, and I'm not
necessarily-
against it.
Right.
Go for it.
But that
Negotiate your
can't be-
10 generic drugs.
That can't be the most innovative thing we do in healthcare this year.
That's
or,
right.
you know,
These are
last year.
That's right. These are
Right.
things around the periphery.
Right.
These are shiny objects. These are distractions from the core issue. We are not talking about the root causes of chronic diseases in America, and that is what costs so much. And we're not making progress. We're going backwards. Life expectancy is going down. Infant mortality is going up. And it's like no one's job. And the NIH is not studying food as medicine and the role of the microbiome in health, even though we have incredible new research on it.
That's a good chapter too, yes. So let's be, I'm not always the glass half full, but I want to you do offer, this isn't just here are all our blind spots and, you know, nothing we can do about it. How do we move forward? There is such incredible science. Like I will say, you and I were both in training when if someone had stage 3 or 4 lung cancer, you know, we would kind of say, get your stuff in order, your survival rate at 5 years, but enter monoclonal antibodies, enter immune therapies, checkpoint inhibitors. There's some of these moments in medicine where you kind of think, this is incredible. So there are those moments. What do we need to do to take that forward to kind of expose the blind spots, deal with them? And I agree, chronic disease, not just because it's kind of what my colleagues and I deal with every day, but you know, we're screening 10-year-olds for cholesterol, for metabolic panels. I see my own children who like went to their pediatrician, one of my friends in the back knows this, you know, dangerously in the like overweight to obese category. And I have all these resources and I have no idea kind of how to fix anything. It's what you want to do as a parent, fix everything. And so what do we do, Marty? How, if I'm sitting and reading this, how do we make it better from a system perspective? And then how do I do it as a patient?
Yeah. Well, first of all, I think we need to empower physicians. They are curious about these things. So we need to stop telling people, put your head down, focus on billing and coding. We're going to measure you by throughput. If you have a big idea, you come out of training, you have a big idea on a whole new approach to cancer or autoimmune diseases, some let's say, a fresh new idea, you will be told, put your head down, focus on a K award, an NIH grant where you will have a small incremental discovery in a legacy area where the senior guys already believe this is where we should be focusing.
Right.
We don't have Ben Franklin thinkers anymore. We don't have these big ideas. So I think we need fresh leadership.
Yeah.
We need to reallocate our research funding. The NIH has been funding research on Japanese quail taking cocaine, watching their sexual activity.
I'm not sure that's really an NIH.
No, that's a real NIH grant. It's a real NIH grant.
Okay.
And, you know, so how about research on food as medicine and the 287 forever compounds that appear in the umbilical cord of every newborn today that we don't understand, that are not present in newborns in Japan? How about
But Marty,
the
it's not
arsenic
just the
levels?
NIH. We should be doing this in medicine, even in medical education. Like
Yes.
this, I mean, and there are, I think, movements to change the curriculum, how doctors, how nurses, how allied health professionals train. But have we ever asked anybody to kind of be curious and to think about things in a different way? I can't think even today of a curriculum that exposes that.
Here's the, I think the problem with medical school curriculum, because it's a big part of our culture, is that it's all medical school curriculum are in the United States are controlled by one small private company monopoly with 19 board members. And historically, they have functioned like dinosaurs. They insist that you memorize the intermediate molecules from memory on the exams of the Krebs cycle, and you do it at 3 different points in your training. Why? What are we doing? We got these giant blind spots.
Right.
We should be encouraging these young, bright, altruistic minds who, with fresh ideas, they're incredible. They have like triple majors in topics I've never heard of before. Let them come in with big ideas. And for the first thing we do when somebody joins the profession at age 21 is we tell them, memorize and regurgitate these things. And if a medical school wants to do something different, they can't, because they
Right.
have to teach to those exams. So colleges don't work. There's not one central company that controls the curriculum of every college in the country. So you have colleges try new things, and that's how we advance education. I think we could benefit from that in medical education as well.
All right, we're going to get to the part where we have time for the audience, so those of you with questions, we're too close to Washington, D.C. to ignore this. So, Marty, you're in the room, you're in 2 different rooms. You'll get a chance to do this with Kamala Harris. You'll also get a chance to do this with Donald Trump. So you get a chance to kind of give them, you know, in this chaotic hurricane of a moment, like what you would want them to think about to advance any bold idea. And you know a lot about how like the bureaucracy gets put together. What are 1 or 2 things you would tell each candidate? They can be the same thing, or you can tell them each different things. It's up to you.
Well, I think there's a lot more agreement on health
I agree.
than the polarization of our social media and the echo chambers
Yeah.
of cable news would suggest.
Yeah.
They're creating these sort of phony battles, sort of fake fighting over should Medicare negotiate the price of 10 drugs that the pharma companies already jacked up the price of, knowing that was coming in advance anyway.
Right.
I mean, it's kind of fake fighting. Every American is united, and there's broad consensus that we want to fight corruption. And we have corruption in medicine like we have corruption in other aspects of government. 90+% of the people deciding our guidelines for food that inform our school lunch programs have conflicts of interest with the food and pharma industry. We need fresh new leaders. We need to fund research on basic things. We need to talk about treating diabetes with cooking classes, not just throwing insulin at people. We need to talk about our school lunch programs, not putting every 6-year-old on Ozempic, as the American Academy of Pediatrics is pushing to do right now. Maybe we need to talk about environmental exposures at the NIH that cause cancer, not just the chemo to treat it. We've got to talk about food and our poison food supply and the environmental exposures that are driving some of these things, because the age-old dogma that the sickness in society is the fault of the person is something we have got to change. We've got to change the culture. We have been saying that forever. Why are all these things going up? Well, the books will tell you obesity and smoking, obesity and smoking. Well, you know what? Smoking's way down now. We can't blame that much anymore. And obesity is a symptom of another problem. and that is the underlying poison food supply in the United States.
All right, well I can't think of a better way to kind of end on the prescription note, so it's not just about talking about the problems. There's very clear solutions and pathways. Let's go ahead, I know we have, and I think we're gonna have both mics, as we said, so and if people are feeling like they don't want to ask a question, I have plenty more. Oh yes, there we go.
So you mentioned the NIH, and as someone who's, fought for grants for 20 years at the NIH, I'm interested in a little more information about what you see as a solution. There's been a House committee recommendation that you may have seen to reorganize the NIH, reduce the numbers of institutes and centers, and then think about ways to change not only the review process, which rewards those who are already well-funded,
Right.
And to your point, are doing more incremental science, the R01 that ends with -30,
Yes.
35.
Yes.
That's right.
So talk a little bit about further thoughts on reforming the NIH from the review system to the way grants are given, to the length of time it takes to get a grant these days, so that by the time you're funded, your idea is at least a year or two old. I'd be interested in more.
So instead of awarding grants based on who has the highest score and the most votes by the professors at the NIH, how about funding grants based on which grants have one positive vote and then put it into a pool? Because if one person thinks that's a good idea in that old guard study section committee, then that's an idea that I think we should pursue. We need term limits at the NIH. I was talking to a friend at NIAID. This is going to get us in trouble. I know this is recorded, and this is in the public record.
It's fine, yeah.
Yeah, you can cover your face for a little bit here.
fine.
You're not associated with me. So, he was describing this professor who's in his 80s, who's like not even present, and all his ideas are old, and they were frustrated with him. And I said, oh, well, is this professor kind of like post-prime, like not really, what's their title? Like, what's their job? Like, I assumed it was somebody who's very peripheral. Oh, he's head of virology at the NIH. Not an important job during the pandemic or anything like that. And so I don't think the heads of the NIH should serve terms longer than some African presidents. I mean, Mugabe was there for 38 years as president of Zimbabwe. How about some fresh ideas? How about some new leadership? How about we don't reward people who have had 15 grants before, and we reward people that haven't had any grants? And we need to study the microbiome. Gut health is so central to overall health. An incredible study out of the Mayo Clinic just found that kids that take antibiotics in the first few years of life that are known to carpet bomb the microbiome and alter the composition of those millions of bacteria that normally line the GI tract, kids who took antibiotics the first few years had a 20% higher rate of obesity, 32% higher rate of attention deficit disorder, 21% higher rate of learning disabilities, 90% higher rate of asthma, and a nearly 300% higher rate of celiac. All these chronic diseases have been going up in the modern era of messing up our microbiome with antibiotics, ultra-processed foods, C-sections. Now, antibiotics and C-sections save lives, but they're also overused. An estimated 60% of outpatient antibiotics and 40% of C-sections. We're messing with Mother Nature in a way we don't understand. And there's a massive signal in the data correlating gut health and the microbiome with all these diseases that are going up. Colon cancer is going up in people under 50. You've seen that? Well, a study just came out in JAMA Surgery correlating it with being born by C-section, right? So there's all these correlations we're not talking about, and instead I think they're too busy funding research on bat coronaviruses in Wuhan or something. I shouldn't have
As
said
someone
that,
who's
sorry.
had 2 C-sections, now I'm like, God, more guilt that I need as a mother. All the things I've done wrong are just getting like knocked out. All right, I'm going to do my best to moderate so that we can get rapid fire and get everyone's questions in. Over on this side.
Hi, you talked about the rigidity in medical education, medical thought, and I believe part of that is the emphasis on algorithms. And one of the problems with algorithms were started to standardize care and then also to serve as a base so that nurse practitioners and physician's assistants could practice medicine perhaps without the full background. And the problem with algorithms is the patient doesn't always read the textbook. They don't always present with the classic case. And populations are a normal distribution. And those algorithms are made for the mean. They're not made for the people out on the tail. So it gets so when a patient comes with something that's a little off and the person has gone through algorithm, the problem is no longer with the treatment. The problem is with the patient because he or she isn't matching the algorithm. And I just wonder if you could speak to that.
Thank you, and I love that point. Thank you for making it, especially in my field of cancer and surgery. You got to customize. How about what the patient wants? That's not in the algorithm, right? We got to individualize. Corporate medicine loves algorithms. The fee-for-service churn machine loves algorithms. But maybe we need to promote critical thinking. Maybe instead of, forcing algorithms where there's no evidence, we see that, maybe we should be teaching the critical appraisal of medical literature. And that is a lost art right now. That's probably one of the most important skill sets in all of medicine. I saw Dr. Caitlin Hicks was here. When we have a research team that is focused on the critical interpretation of research studies, you would not believe how frequently in medicine, if somebody gets the finding that they like, the results they like, this is amazing science, even though the research is flawed. And if they don't like the results, they dismiss it, even if the research is impeccable. And so we've got to teach good statistical interpretation of research. Thank you.
That's getting harder with large language models and AI, by the way. 'cause
Yeah,
I think
and
there's-
politics,
and
yeah.
Yes. All right, on this side.
Thank you, Dr. Mary, for the lecture. I'm a public health physician, and it's good to learn that HRT doesn't increase breast cancer occurrence. Then, if that is settled, what next? The next thing we should promote is the usefulness of HRT. I learned from medical school, and I think it's still correct, that it improves sexuality and also dyspareunia,
Yeah.
So if that is so, we can, up on that. And the question now is, as a public health physician, we learned that if there is any drug, let me use the word drug, whether novel or old, and you are in a position to take a decision, you have to, now science has backed that this is this is that. But even where there's no backing, you can still use your own intuition by choosing one of three. Number one is, if it's harmful, don't give your patient. If it's harmless, go ahead and give. What happens between the two? Thank you.
Thank you. So, great points. We are trying to go, and so you're right, 60% of medical decisions are discretionary overall. It's different by specialty, and 40% has scientific support. So we do need clinical wisdom, and we need to put that together with the best available evidence. Hormone therapy does improve sexual health. It's saved marriages. It's really a miracle, but a couple caveats. You have to start it within 10 years of menopause, or it has the reverse cardiovascular effects because the vessels have already hardened. You don't get the benefits. And if you have a history of blood clots, it's not recommended. And some people can't tolerate it because of endometriosis or headaches, but the vast majority of people benefit from it. On the other point, a bunch of us are trying to go directly to the public. We have to educate the public. It used to be the journals controlled the narrative, and they had they controlled the airwaves. And now you've got a bunch of us. Peter Attia, who was with us at Hopkins, Casey Means, Mark Hyman. We're trying to go directly to the public and educate them on these big topics of health. So Peter Attia, who you may know, has a famous podcast. He helped me a lot shaping the book and picking the topics where there's a lot of misconception or people do not know the truth on whatever health topics that are big today. So thank you for your question.
All right, on this side.
Well, if you ask a veterinarian what does a dog eat, they know exactly what nutrition a dog needs.
It's true.
If you ask
A doctor, they
a
don't.
horse doctor,
Yeah.
they would know. The problem is that people don't want to eat what humans are supposed to eat. We've been on, as Homo sapiens, we've been on this earth about 100,000 years. And most of that time we ate plants. And that's the secret. We have, I'm a retired GP. And near the end of my practice, I went to a physician's committee for responsible medicine. They are finding the answers. And NIH is funding some of these studies, long-lasting studies. They're putting, and I agree with you about the toxins. They don't teach doctors anything about toxins. But we also don't get nutrition. We don't get any studies in nutrition. And the industry, the meat, dairy industry, they actually fund the nutrition education for doctors and nutritionists.
I'm going to push you to ask a question.
Yes.
If you, I'm just for sense of time. Do you have a question for Marty?
okay.
Or-
I can comment on
All
that
right,
point
okay.
if you'd like me
Yeah,
to.
we need to eat plants.
Yeah,
Everybody.
that's the
please.
take home. Yes.
Things that are whole
uh-huh.
foods, yeah. So
Right. I don't like eating plants all the time, though. It's so much nicer. It's so much nicer to eat Pringles. Let's be honest. Yes, this is
I was asked
okay.
to
Pringles.
I was asked to give the keynote speech for the big nutrition conference of all the dietitians in America. It's the big nutrition conference. And I like to push the field. And so I said, maybe we need to question some of the dogma that we've inherited, like all adults need to drink 3 glasses of cow's milk every day. That is a current national nutrition guideline. And after that speech, a woman came up to me and she said, I'm with the American Milk Association. And I
take pause
take
with what
pause.
you said,
And
Doctor.
I find out they are the
Largest lobbyist.
the
Oh,
second
yeah.
big sponsor of the conference.
Yeah,
And the other sponsor was Coca-Cola.
yeah. There's a lot of, it's a lot of money in bad nutrition on this side.
Yeah, so I appreciate the remarks on big thinking and communication and having people think differently and promoting that communication. 34 years ago last month, my wife and I our child was born with a rare condition. He was rushed here to Johns Hopkins. We didn't see big thinking. We saw a silo. They had a rare condition. When asked finally by myself, how many times have you seen this situation? The response was once in the history of the hospital. My wife and I, I haven't been back here in this facility since that month after my son arrived in that hospital. We came here to research the things that they were saying and found out it didn't make any sense, that they were suggesting things that nowhere else in the world were they doing the kind of procedure they were going to do on our son. We forced the conversation with another institution. She has a brother who's a doctor who researched it around the world and found out there was somebody in DC and somebody in Philadelphia. Now, if one doctor could go and do that kind of a research, then why does Johns Hopkins and other institutions not have communication? Maybe it's changed in the last 34 years. When you talk about big thinking and communication, when you have situations like that, you don't sit in a silo, even as big as Johns Hopkins, and say, well, the best thing we can do is what the book says, and then you don't listen to the people under you. Now, we spent a month, as a parent's perspective, parent and with a patient there dealing with a very rare condition, and we watched the nurses in the NICU and the PICU, in the most intense places in that hospital, not being listened to by the surgeons, who really had firsthand a look at what's happening. The younger, 2-year doctors? Fellows are communicating at their level and not with the chief surgeon. And so as a parent in that environment, to be able to recognize this is happening, I'm hoping things have gotten better in the last 34 years. My son is doing well and living here in Baltimore. Having said that, though, he wouldn't be here today, and I'll just give you one example. His stomach would be attached to the side of his neck if we didn't come here to this library and tell him you're not going to do that and force the conversation to do the proper procedure.
Wow.
That's incredible.
It's incredible. Thank you for sharing that story. And we are too siloed. There are benefits, and there are pluses and minuses. Everything is nuanced, right? And so there are benefits to this hyper specialization. Heck, in our GI department, there might be 50 faculty, and I think they probably have 20 subspecialties within. And so, there's a hepatology person and a bile duct person and a pancreas person. So there are pluses and minuses, but sometimes we lose track of the fact we're treating a whole person in our hyper compartmentalization, and sometimes nobody's in charge. And sometimes, honestly, we lack humility. I think the worst thing that we've done to medical students is we've put them out there with no knowledge of nutrition, but with the perception that they're the experts in nutrition. And that's the worst combination. I just talked to a friend who graduated from medical school at another school, and he said there were 2 hours of nutrition, and we talked through what he'd learned in those 2 hours, and it was all misinformation. It was the government food pyramid and the food industry stuff, and it would have been better for him to have had 0 classes in nutrition because it was such corrupted information.
We've about 10 minutes left. We have 5 questions.
Yeah,
so
we're gonna try to do this and not dishonor anybody up
we're
here.
going to get everybody in, but please be brief with your questions.
So I just have a question about a different approach to, I know your book discusses peanut allergies, and I'm a parent of a child that has peanut allergies. And when she was diagnosed with the allergies, they did the allergy testing, the only thing that was said to us was, here's an EpiPen. That was basically it. And so she has all sorts of food allergies, celery, fish, peanuts. How could that conversation have been different for us as the parent of a child that has a peanut allergy, and we don't have those allergies?
Yeah, so there are so many ways now that we're recognizing you can reintroduce the allergen at very low doses, but it's hard because the body reacts in a small way. So it's easier to just avoid the allergen, but there are new ways now in allergy science where they're discovering new treatments, and there's a drug called Xolair that sort of suppresses the immune system as you get re-exposed. It just got FDA approved in February. It was FDA approved in Europe 19 years ago, if that says anything about our FDA. By the way, the F in FDA is supposed to stand for food, and the H in NIH is supposed to stand for health. But the modern day peanut allergy epidemic that we live with today was ignited by the medical establishment with a dogma 24 years ago when they declared that all children should avoid peanut butter exposure in the first 3 years of life. And they forgot about a basic principle called immune tolerance, which means if you don't have any exposure, you're more sensitive to it. And they ignited the modern day peanut allergy epidemic, which is real and it affects people and people don't understand it. And it wasn't until 15 years later that some doctor finally did the randomized control trial randomizing young children to peanut abstinence versus early peanut butter exposure, and found that 8-fold difference in allergy rates, including a massive reduction when you introduce peanut butter early in the severe allergies. So it is tragically the United States, where we had this dogma, has the worst peanut allergy epidemic in the world. You don't have peanut allergies in Africa. You don't have them in most parts of Europe. It is an American problem as largely a consequence of medical dogma by the medical establishment.
All right, this side.
Thank you, doctors, for sharing your valuable insights. I'm Ibrahim, an undergraduate senior studying public health, and I'm actually deciding between pursuing medicine and a career in epidemiology. Something I highly resonated with is our silence or ignorance towards our failure in timely detection of chronic illnesses. As someone who has spearheaded this narrative in both research and clinical settings, how do you think I can position myself to most effectively reveal these blind spots and help empower the population to prioritize prevention over cure?
Well, I encourage everyone in medicine to get some formal training in epidemiology, at least if they're interested in these big topics. We've been sidetracked with the term prevention in public health. I'm not talking about prevention in the classic medical sense. I'm not talking about more mammograms. I'm not talking about more colonoscopies. I'm talking about the root causes of disease. And I think medicine has said, oh yeah, we like this. Let's move the age of mammograms in low-risk women from 50 down to 40. That just happened, by the way. Now you're officially supposed to get a mammogram at age 40. No randomized controlled data to support it. I think flimsy data anyway in that age group. We're giving women radiation. Maybe there's downsides to that. And so I think the modern medical industrial complex has taken this concept of root causes of disease that I'm talking about and said, oh, that's prevention. We need more medical interventions in young, healthy people. So I think that's just something to be aware of. That's a very fine balance.
It is. All right, on this side.
Oh, I don't want to be the last one.
No.
But I guess, so hi, I'm a primary care physician, preventive health physician, and future addiction medicine physician. So I have this interest in social drivers of health. And the question that I have for you is, you made this comment about how we all agree about health, and I'm actually going to say I disagree. I think that we may agree about what health is, but clearly it's not showing. It's changed over decades, where meat was promoted for quite a long time by the USDA, and then milk was promoted by the USDA for a long time. Eggs was terrible, and now eggs are good again. And so if you were in the room with the USDA or you were in the room with the Department of Agriculture, how are you going to, I mean, right now I'm seeing that WIC is not being funded anymore. They're trying to cut WIC. They're trying to cut school lunch budgets. They're trying to cut all of these that help promote the healthy eating. And so if you were in the room with those groups, how would you get these agency experts to make a change, to hear what health is now?
You know, if you say I don't want my baby to get the hepatitis B vaccine in the delivery room upon birth, you will be labeled an anti-vaxxer, and the medical establishment will pile on and come down on you in incredible fervor. And so we've created these issues, and you know, I'm not addressing the topic of vaccines, but if we took 1/100th of that enthusiasm and talked about food as medicine in our school lunch system, we'd have a healthier population. If you took 1% of the Medicare budget of $1 trillion a year, and you could feed every poor child in America with organic school lunches. But these are the issues that live in the blind spots. So these are things we need to be talking about. We need research. I'm glad you're doing what you're doing. If the addiction thing reminds me of, you know, the tobacco food scientists who made sure tobacco was addictive. When they had the global tobacco settlement and tobacco was winding down, they all moved over to the food industry. And so Fruit Loops is made in 2 versions by Kellogg. One version for Canada, where the ingredients are banned, and one in the US where they're not banned. So how about we start with the 1,000 food ingredients that are banned in Europe that we
It's like
routinely
baby
have
formula.
here.
Take
Baby
anything
formula.
that we talk about everything. It's in all of them. I always say kids don't vote. That's what it comes down to. Kids don't vote. They're not like enough of a demographic that people care about until they vote. That's partly what I saw with politicians. All right, 2 more. We're gonna get them in under a minute each.
Hello, doctors. Thank you for being here and speaking with us. One of the big blind spots that I see in the American health system is focused around mistrust of patients to doctors. And I think that one of the ways we could fix that is kind of building up our intuition, or doctors' intuitions back up. And I'm wondering how exactly you think we can switch from a more memorizing, fact-based learning to an intuition-based learning.
I find doctors who have the best trust and rapport with their patients are the ones that are the most honest and transparent, not the ones who have memorized the most drugs and enzymes in medical school and are the smartest. And I think people are hungry for humility. I think people can be very forgiving if you're honest with them. As you may know, a study just came out last month showing that we just witnessed the largest decline of public trust in any profession in the history of the United States. The trust in doctors and hospitals went from 70% just 5 years ago to 40% today. We've got to rebuild that public trust, and I think the elements you described are exactly how we do it.
Thank you.
All right, last question. No pressure.
Thank you. Thank you. So that actually segues to my question. Thank you for mentioning this event to me yesterday. My name is Michael Vinluan. I'm the president of the American College of Legal Medicine. It's the National Society of Medical Doctors who are also attorneys. And we are working on many issues that affect the practice of medicine in the United States, from the reduction of Medicare reimbursement to the use of AI in healthcare. But here's my question, and it may not be within the scope of your book, but I think it may be a blind spot. the American Medical Association has been fighting scope creep, wherein non-physicians are doing the jobs that physicians do. And currently, it's within our ethics committee to see how we can work with the AMA about this issue. Do you have any thoughts about this current issue, whether you consider it as a blind spot
So many
at
thoughts
the
you
moment?
have, I know. So many
You
thoughts.
might be able to answer that better.
No, I mean, I think it's why the public trust has declined. We're widgets. We're not valued for training our intuition. And in Washington, D.C., there's a law that passed for podiatrists to be able to do hand surgery. Tell me what makes sense about that. You know, who do I want doing my hand surgery? And so I find myself in rooms of corporate America. You've written other books on this, where decisions are made about staffing based on what an FTE could cost, how we can cut costs, how we can apply utilization management. And the person over here that talked about kind of under the curve and the mean and the kind of median, like that's what we're building for. Yeah. And I don't see I would say the cancer community has actually done a pretty good job of like a bit more of advocacy and an outcry. Yeah. There's no advocacy organization for chronic disease. Yeah. There's just not. Yeah. And there's nobody that's going to speak up for people who are like just, you know, kind of have like this, that don't have something that's like sexy enough to get a, you know, Cas9 or a gene therapy. Yeah. But I'll let you close because you get the last word.
Great points, Kavita, as always. The phrase I heard most recently that I love the most is chronic diseases, now that seen in childhood, something we can all agree to address? Can we love our children more than we hate each other? And I think there's something beautiful about saying, let's rally around something where there should be broad consensus and not let big pharma, big ag, big food tell us how we should be governing and regulating this country. So I'm really excited about this book. Thank you for your support. Thank you for getting the word out on it. I was blown away when I saw we were #2 on Amazon overall in books, and it's not even out. I mean, technically it comes out tomorrow,
I still haven't gotten my copy.
So thank you.
I know.
Thank
Great.
you.
All right.
Please help me thank our moderator for this afternoon, Dr. Kavita Patel. And this afternoon's author, Dr. Marty Makary. So Dr. Makary is right. The book comes out on Tuesday. Thank you to our friends at Bloomsbury Books for letting us sell the book early. Snug Books has books for sale. If they sell out, they can sell you a book and they can make sure they send it to you. So please, no concerns there. Marty's going to be over here signing your books. Thanks again. My colleague, Sophia Nalawi, will be organizing the line. Line starts right there and it'll hug this wall. Thanks for coming out.